Good morning, everyone. I have the great pleasure of introducing our speaker today. Dr. Michael Lang received his medical education right here in Eastern North Carolina and loved it so much he decided to stay for a combined residency in internal medicine and psychiatry. Although he did veer off to Duke University for an electroconvulsive fellowship, he promptly returned to our fine institution. He is now a clinical assistant professor and associate program director of the combined internal medicine and psychiatry program here at Brody School of Medicine. Dr. Lang has remained committed to our medical student and resident education by participating in many professional and voluntary committees throughout the years. He will be speaking today to us on managing depression in primary care, a pragmatic review of the evidence. Please join me in welcoming Dr. Michael Lang.
Good morning, everyone, and thank you for coming. So, as my introducer stated, we're going to be talking about depression today in primary care. And this is part 2 of our NC Accept lecture series, which is a educational alliance between Duke, UNC, ECU, and Wake to educate primary care docs on common topics in depression. And when I was first looking at this talk and screening it when it was presented from UNC, it reminded me of a lecture that I saw here a few years ago from the Department of Nephrology. I think Dr. Haynes and Dr. Boland and our then dean, Dr. Johnson, were talking about chronic kidney disease in North Carolina. One of the main thrusts that they had at that point was internists needed to be more comfortable with chronic kidney disease because there are nowhere near enough nephrologists to manage all of it. The same could also be said of depression because there's a rather significant dearth of psychiatrists in this area. Just to give you an example, it takes on average about a 3-month wait to see a resident in ECU Psychiatry Clinic right now. And that is assuming double booking and walk-ins. So it's going to be a while if you refer a patient before they can get to be seen. And because of that wait, we often have a 50% no-show, and then they return to you for further management. So one of the goals of this talk is to give you a step-by-step algorithm of how to treat them from start to finish, and to show you that it can work if you apply it. So our objectives today, we're going to identify key concepts of evidence-based depression care, review screening with a depression instrument, clarify some key points for the diagnosis of depression, examine a measurement-based care approach to managing primary care depression, and some prescription tips. So, as recently as 2009, the U.S. Preventive Services Task Force recommended screening adults for depression with staff-assisted depression care supports, okay? So what they want you to do is not only identify it, but then treat it. Traditionally, what happened outside of the psychiatric realm was if a patient was identified with depression, they were then promptly referred. So we had kind of a silo mentality going on in medicine. The internist did the internal medicine problems, and the psychiatrist did the psychiatric problems, et cetera, et cetera. Now we're moving away from that. We're going more and more to an integrated care paradigm, okay? So what they want to try to do is have the internist manage as much as possible before he reaches out to the specialist, okay? And one way of making you more comfortable with this, as I'm sure not many of you are very good with a clinical psychiatric screening exam, is to use a screening instrument. And it really does not matter what screening instrument you decide to use, so long as you are comfortable with it. Most of them that are out there, whether it's an SCL-70, excuse me, a quiz or a PHQ-9, are fairly well validated. Your goal is you want it easy to use, quick to administer, and to give you an accurate answer, okay? And when you use it, and use it regularly, you will have pretty near identical treatment outcomes with the psychiatrist. And let me show you some data. This comes from our good friends at UNC, Bradley Gaines, that was looking at the spectrum of depression across settings, not only in primary care, but in psychiatry. And as you can see, if you break down Hamilton T depression scores, the internist or the family practice doc is seeing the exact same level of depression as the psychiatrist is, okay? And that has been seen and replicated across a number of studies. And what it does is it reinforces the notion that the internist is the de facto psychiatrist in this country. Arguably, internists write far more antidepressants than psychiatrists do, just from a volume basis. So it's important that you get comfortable with this because you're going to see it a lot. So I want to take a moment to adjust some of your treatment goals as far as depression is concerned. Traditionally, we looked at success as a 50% reduction of symptoms, and that would be a response, and that's what a response means, 50% better, and that was the highlight of success. What we now know, and studies from Wake Forest have proven, is a 50% response basically means you're going to be dealing with this in 6 months. Residual symptoms of depression increase the likelihood that the syndrome will relapse. So, rather than response, we would rather you go for remission, which is essentially an absence of symptoms, or as close to absent as you can get, okay? You want to ensure a maximum but tolerable dose for at least 6 to 8 weeks before deciding an intervention has failed. Depression is a game of patience because your clients are going to be miserable, they're depressed, they're not functioning well, and unfortunately we don't have anything that is going to work rapidly. At least 4 weeks is going to have to go by before they see any realistic response at all. So what you have to tell your patients is to take it even if they don't think it's doing anything. Take it anyway, take it consistently. Because the top 2 reasons any of these drugs fail is either inadequate trial, which is number 1, or inadequate dose, which is number 2, okay? Identical remission rates can be achieved in either primary and specialty settings when similar evidence-based care is provided. So what I'm meaning to say is you can do it. It's going to be possible and it's going to be successful. You just have to get comfortable, okay? Again, should the first treatment fail, try again, all right? Any given antidepressant with an initial use is going to have a 60 to 70% response rate. That said, you're going to have a 30% failure rate on average with any given one antidepressant that you try. So it would make sense to switch or augment the current treatment if they're having somewhat of a response, okay? And I'll get to augmentation shortly. The likelihood of remission after 2 well-delivered medication trials substantially decreases. So the point that I want to make is you try one drug, you give it a really good shot, you stick with it, and it fails. Try a second drug. It's not going to be a problem. You may stick within the same drug class, you may elect to switch. That'll be up to you. But try a second drug. If the second drug fails, you should probably call psych because you're starting to move toward refractory depression at that point. And those are going to be people that are difficult to manage. I have some folks in clinic that have failed 17 drugs, and I'm having to use 2 or 3 drug combinations. And that's when you start to see those patients, is after 2 drug failures. So give it 2 good tries. After 2 good tries, call psych. Okay, so I'm going to walk you through a typical treatment phase for depression. So let's say you've got, Miss Susie Q who comes to clinic, and she was starting off doing well, functioning, going to work, paying attention to her husband, etc., and she was euthymic. But now depression has started to set in. And so now she's starting to fall on off, and she's going to hit a line at some point where functionality is going to be impaired. And that's when it starts going to clinical significance, okay? These are symptoms when she loses functionality. Now we have a syndrome. And at some point, she will probably hit rock bottom. And around in here is when she's going to come to either your attention or to psychs, depending upon where she goes. So here you're going to see her, and you're going to diagnose depression. This is spot 1. And you're going to put her on an antidepressant. Let's say you put her on Zoloft. And let's say that it works. All right? So she's going to start getting better over 6 to 12 weeks because naturally she's going to be completely compliant. And she's going to come up, and now she's 50% better, and that is a response. Traditionally, that is where we stop in the primary care realm. What I'm saying is you don't stop there. As you're continuing to see her, you will aggressively push her dose until you get her back to remission. You want her completely functioning, back to paying attention to her husband, etc., etc. All right? Now, let's say you decided not to be aggressive and you left the dose. Her likelihood of relapse is going to happen again. All right? But you were good doctors, you titrated the dose, and you got her to remission. Remission, again, is not where you stop, all right? Let's say she comes to me and I see her and now I've got her to remission and she says, well, I'm ready to stop the medicine now. I go, no. You're going to keep that medicine and you're going to take it the exact same way you've always been for 6 more months. And I will touch base with you in 3 and in 3 again. And if you don't have any more symptoms to say to me now than you did when I first saw you in remission, then we'll talk about tapering. But there is a 6-month lock-in phase where you maintain that level of serotonin or norepinephrine or whatever it is you're adjusting. If you don't do that, you're going to have relapse, okay? Sometimes I'll just keep the patient on the medicine if they would elect not to take that chance. A lot of times I will try to taper. Another point, it is a myth that patients wind up on antidepressants for life. 2 out of 3 times I am able to successfully taper the drug off and they go on about their merry way and they come back if they need me, okay? Let's say they come back after they've had stabilization. This is a recurrence. If this happens, I treat them all over again, only their maintenance is a year at that point. Okay, let's say they flop down again. After a 3rd time, their likelihood of relapse is 98%. So it does not make clinical sense to stop the drug at that point. So it's a 3 strikes and you're out kind of deal. But again, to highlight, this is a long time. It is a game of patience and you have to stick with it to maintain good response. Okay, screening tools in primary care will help identify and clarify cases of depressive illness. You can also monitor response. We are in an era of quality now and not quantity. So it is not enough to write in your report that the patient feels better. Medicare, Blue Cross wants to see how you proved that. A lot of places in internal medicine, that's easy. The A1C went from 9 to 6, success, okay? But what does better mean? In psych, it's a little bit more abstract. So screening tools and monitoring tools help you quantify in an objective way if what you're doing works, okay? And so this total score will have clinical relevance for you and it will help you make a decision on whether what you're doing is working or not. Okay? From O'Connor in 2009, with a meta-analysis of 9 major randomized controlled trials, primary depression screening and care management, especially if you've got assistance and follow-up, can increase depression response and remission. It's like any other diagnosis or lab. If you're going to order it, you need to be prepared to follow up on it. It is not enough to refer to psych. You may not have psych. In many areas of Eastern North Carolina, for example, there is not a single psychiatrist for a given county. So you're often on your own. So you have to chase it down by yourself. But again, this can be done, okay? If you didn't follow up on it, it's like you never did it. You might as well not have screened, okay? So make sure that you adequately apply a good algorithm. Okay, so how do we measure depressive severity? The screening test that I would like you to use is the PHQ-9. And why is that? Because I know how it is in a primary care clinic. You are rushed and you've got 10 other medical problems that you've got to deal with. So you need something that is quick, accurate, and easy to use. And the PHQ-9 is all 3. It's pretty well validated. It has a sensitivity and specificity greater than 95% for detecting depression. And it was pretty much developed straight from the DSM-5. When the DSM-6 comes out, it may be completely different, but they will again adapt it to the current diagnostic criteria. And what the PHQ-9 does is it shows over 2 weeks what their symptoms are, everything from feeling down to poor appetite to trouble concentrating. And then they list from their report how much this is bothering them. And then you can either add them up or multiply them by their value, whichever way you prefer to do it, to get a total score. Now, there is a 10th question that I could not get up here because of space, which relates to the level of functional impairment. How well are you functioning due to the above over these last 2 weeks? And then they rank that from I'm functioning fairly well to I'm not functioning at all. And then all 10 questions gives you a total score. This can usually be done if the patient is motivated to do it in less than a minute, okay? I would propose that maybe this could be done during the nursing assessment, especially if they voice symptoms of depression. So you'll have that when you walk into the room. So what do the scores mean? Well, if it's 1 to 4, then you're fine. You move on. If it's 5 to 9, that's in that symptom phase. They're starting to feel something. So you can elect not to treat, especially if they're functioning well. Functioning is key to essentially every psychiatric diagnosis, all right? So you might repeat it the next time, just kind of keep it in the back of your mind, okay? This is kind of like the equivalent of elevated blood pressure without a diagnosis of hypertension, okay? Now, at 10, that is clinical significance. So now you've got to do something. You could consider sending them to a counselor, or you could elect to elicit a drug. Either or would be fine at 10 to 14, okay? At 15 to 19, they need a drug. Now, you can do both, but at very least, a drug needs to be in there. At 20 to 27, they are pretty bad off. So they definitely need a drug. You should refer them for a counselor. You may even want to run the case by phone by a psychiatrist if you have one, just to go, am I being aggressive enough? Suicidal ideation is probably going to be in that range. So you want to definitely be aggressive at that point. Okay? Now, once you have a positive, there are two things you have to quickly rule out. Number one is mania. And as a general course, mania is much less common than depression, even in a bipolar patient. They may have 3 depressive episodes for every 1 manic episode, and they tend to forget the mania, which makes it hard. But you need to at least ask, has there ever been a sustained period where you were the exact opposite of what you're feeling right now? Okay? And if there has been, then you have in the back of your mind bipolar disorder. If they're psychotic, has there ever been a time where you thought your mind was playing tricks, you heard voices others didn't hear, saw things others didn't see? That is psychosis. Don't mess with mania or psychosis. Call psychiatry. I would not want to put bipolar disorder or schizophrenia on anyone in the primary care realm. Do not pass go, refer to psych in that case. Believe me. Okay, so looking at a measurement-based care plan for depression, you want to monitor the severity and how bad the symptoms are with a PHQ-9 or whatever else you want to use. If you put into Google a depression screening instrument, 10 are going to fall down. Just pick one that you're comfortable with and use it consistently. Okay? Consider medication side effects at each critical decision point. What is a critical decision point? An office visit, when you are physically eyeballing your patient. Because half of a depression screen is what you see. Because patients can tell you, oh, I'm feeling fine, and they look like death warmed over when they come into the clinic. Like they haven't showered, they're coming in their pajamas, which I have seen many times. So sight and sound will matter when you're evaluating a patient. And then you go with your evidence-based treatment algorithm, which is not absolute. There are many eccentricities to psychiatry. Some patients will elect that no matter what, they don't want to try medicine because they don't want anything to alter their mind or whatever the case may be. Sometimes, even though it's against your better judgment, you may need to just go with therapy because it's better than nothing. So algorithm is important, but eccentricities play a role. And then manage aggressively and treat to remission. That is a very important point for depression. Very, very often, I will see a referral that comes to me in clinic, and that patient was diagnosed accurately with depression by the primary care provider. That patient was also put on a correct medication, but it is at a very small, probably clinically insignificant dose, Zoloft 25, and it was stopped there. And so what I do is I double the Zoloft to 50, and I see them back, okay? What I suggest you do is pick 3, maybe 4 psychiatric medicines and learn them. Okay, there are 40 antidepressants on the market right now. You don't need to know 40. Learn 4 and learn their entire dosing range and their side effects, and just use those 4. And don't be afraid to bump up the dose, okay? Usually, depression is going to respond, if you pick Zoloft, for example, between 50 and 100 milligrams. So the only thing you verified with 25 is they probably don't have a major side effect from the drug, and that's all you've done. Titrate, 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 okay? You're realistically not going to hurt these folks with antidepressants, okay? So again, assess response and assess tolerability. After inadequate trial and inadequate dose, side effects are the third most common reason these drugs fail, because the patient has sexual dysfunction and they go, okay, the heck with this, and they stop it. All right. At critical decision points, you make your dose changes, and the goal is remission. Okay, how do you define remission? A PHQ-9 less than 5. A partial response is 5 to 9, and no response is still greater than 10 because they're still having clinically significant depression. All right. Now, as a general rule, you can follow them up every 4 weeks. Why? Because it's going to take you 3 to 4 weeks to see a clinical response. All right. These drugs work slowly. I often tell my patients bad things happen in the brain rapidly. You can have a stroke immediately. Okay, but improvement of neurotransmitter flow takes a really long time, and no one knows why, because these drugs exert their pharmacological effect in 30 minutes. But while you don't see a clinical effect for 4 weeks, we have no answer, okay? So here's a typical patient visit. Now they're looking at you in the clinic, okay? So now you started them on Zoloft, and then you ask them, did you have any side effects from it? Oh, I had a little bit of stomach upset, but it went away, and now I'm feeling fine. All right, so we would call that tolerable. Now you've got your PHQ-9. Did they have any response at all? If they had no response, then you would probably increase the dose to the middle range, and I'll show you middle range in just a bit. If they had a partial response, then you've kind of got a gray zone here. You can increase it or continue it. Let's say they went to remission, success, all right? Let's say that it's intolerable. Oh, I've got sexual dysfunction, or oh, I've got a blinding headache, whatever it is. If they had no response, switch. If they had a partial response, this is the fuzzy area because the drug has worked. And as I will talk about shortly, sometimes drugs work for people and sometimes they don't because it is an individual response. So now you have to ask yourself, is there any way, considering it's responding, that I can make this drug more tolerable? Are they taking their Wellbutrin, which is a potently energizing antidepressant, at bedtime? It happens, okay? So you have them moving in the morning, bingo, more tolerable, okay? Could they take their Zoloft with their morning breakfast? Because food often mitigates the nausea. There's all sorts of little things that you can do to try to make intolerable tolerable, okay? When I'm seeing a patient in follow-up, if they've had absolutely no response, so if I'm not seeing anything, it's a complete flat line, then I would probably switch. If I get any of the barest twinges of a response, even if it is 10%, then they have at least responded. So now I'm thinking it is a dose issue. So if it's nothing, then I would switch. If it's something, anything, then I would probably at least give the drug one more good try with a dose increase before I'd give up on it. So that is a typical patient encounter for depression. Now, of course, you're working this into the diabetes and to everything else, but this can be done quickly with a couple of questions. Okay? So I think the dosage needs adjusting. I'm not nearly as happy as the people in the ads. Okay? And you've all seen them. Does depression hurt? Try Cymbalta at $180 a month. You know, try Abilify for your depression, which we will talk about in more detail in just a second. Be careful about patients that come in requesting a specific antidepressant. And I'll tell you what the data shows here in just a second. So here's a sampling of the drugs, okay? And I'm not going to go into them in great detail because of the data that I'm going to show you in the next couple of slides. But I just wanted to show you the dosing range. If you look at Prozac, for example, you can start it at 10 and then 20 in the morning. That's starting relatively low. The older they are, the more medical comorbidities, the lower I would typically start. That is a middle dosing range for Prozac. And that would be a high dosing range. Actually, the max of Prozac is 80. All right, so you got plenty of room to go up on a dose, especially if they are responding and it is tolerable. Zoloft, I have several obsessive compulsive disorder and bad depressions on 300, and they're doing just fine, okay? Celexa is a little bit different because of the new FDA releases about arrhythmias with this drug. So what the FDA tells you now is if they are over 60, your max is 20. If they are under 60, your max is 40. If they have active heart disease or arrhythmias, Celexa is essentially contraindicated. So you have to use Celexa with a grain of salt and really screen your patient carefully before you use it because you can increase their arrhythmia risk. Okay? 3 others that I will mention, Wellbutrin, which goes up to 450 milligrams per day. Okay, Remission, which can go up to 60 or even 80, and Effexor, which can go up to 300. All right, so I would learn 2 of these 4 and 2 of these 3, and just put them in the back of your mind. Get comfortable with them, and make that your psychiatric armamentarium. All right. Okay, which antidepressant do you use first? I don't care. All right, just learn your 4 and use them because at the end of the day, clinically, at a population level, they are all the same. Studies have conclusively shown with large numbers of patients that only thing that matters is intolerance or response, okay, or problematic drug interactions. For example, Indinavir, Ritonavir are potent CYP3A4 inhibitors. So they're going to make 20 milligrams of Prozac, 40 milligrams of Prozac. So if you have an HIV patient on those drugs, start lower. Okay, that would be a 10 milligrams of Prozac person rather than a 20. So I would just start low. You can still use the drug, just start lower when you're prescribing it. Okay, so just make sure you don't have drug interactions or an intolerance of the medicine, and choose one. Okay. 72 head-to-head trials in 16,000 patients looking at quality of life, response, and other indirect comparisons, outcome of interest, response to treatment. Okay, so large numbers of patients, large number of trials, head-to-head, no substantial difference in efficacy. Okay, there were some statistically significant results, but they weren't felt to be clinically important, and it was primarily individual little side effects from one drug versus the other drug, not how well they worked. So ultimately, from a head-to-head comparison, you get no more bang for your buck writing for an expensive antidepressant versus $3.50 Zoloft at the Brody Pharmacy. They are all the same at a population level. So my analogy to patients is, if I had 1,000 depressed people and I just handed them out at random, they would all do the same. However, from an individual perspective, I have people who are Prozac people. I have people who are Effexor people. So individually, they will respond, and you can kind of get an idea of their response based on their past history, okay? But a lot of times, it's guinea pigging. Not even going to lie to you, especially if I don't have any major psychiatric history to draw from. If they're coming to me and they failed 4 SSRIs, likelihood the 5th SSRI is not going to work. But if I don't have any history and you're operating blind, you might as well just choose one, okay, and see if it works. 60% of the time to 70% of the time, you're going to be fine, okay, because you never know how a person's response to the drug is going to be until they're exposed to it. Okay, patients get greatly frustrated with that because they would like you to knock it out of the park on the first try. Sometimes I do, sometimes I knock it out of the park on the 8th try, so I've struck out several times. That's just unfortunately the facts of life. Once you've got a constellation of symptoms, I have a constellation of drugs that will all reasonably work, and then I pick one and I hope for the best. Right? That's where you lose the science from it, because the head-to-head trials don't show that one is any better than the other, statistically speaking. Excuse me. Discontinuation rates did not differ significantly among the drugs. There were some statistically notable but not clinically significant rates for Effexor because of nausea, vomiting, and irritability, because it is so energizing relative to SSRIs. Okay, you had a little bit more nausea, vomiting with Effexor, a little bit more somnolence with trazodone, which makes perfect sense. It's a sedating antidepressant. I would expect it to put you to sleep. Okay, diarrhea, a little bit more with Zoloft relative to the other drugs. Weight gain, a bit more with mirtazapine. That is what mirtazapine is for. It is an antidepressant that makes people sleep and eat. So when they stopped eating and they stopped sleeping, that is a perfectly reasonable choice. So a lot of times the adverse effects were relative to their mechanism of action. Now, sexual dysfunction is really frustrating for folks, and it is one of the major side effects that lead to discontinuation. You have fewer sexual side effects with Wellbutrin than for the SSRIs. Why? Anything that bumps up your serotonin slows down every single phase of your sexual cycle. Excitement, plateau, orgasm, they all get knocked out with increased serotonin. Anything that increases your norepinephrine advances all of them. That is why we use Wellbutrin for sexual aversion disorder. It increases your sex drive, okay? So you remember I told you that sometimes a drug can be intolerable. Let's say you've got them on Paxil and it's working. They're better. However, they have no interest in sex, and that's starting to cause marital difficulties. I will add a little wisp of Wellbutrin in the morning, 75 to 100. Mitigates the side effect. Moving on. Okay, so there's all sorts of things you can do to keep them on a drug that is working. Because I can't promise you that if I move them from Paxil to Zoloft, that the Zoloft will work. Sometimes it does, sometimes it doesn't. All right. So if you've got something that's giving you a benefit, stick with it as long as you can. Okay. Selection guided by side effects, because there's no difference as far as remission or response. So I don't give Remeron, which is going to make people eat, to a morbidly obese diabetic. Does not make sense, okay? I don't give Wellbutrin to someone with a seizure disorder. That, again, would be problematic. So you look at their medical problems and what possibly has worked in the past, okay? Also, I look at their family history. If their sister had a marvelous response to Luvox, then I'm going to try Luvox first, because there is somewhat of a familial response to antidepressants, okay? So you honestly pick your antidepressant based on their medical history as much as anything else. All right. So now I'm going to talk a little bit about suicidal ideation because this has creeped up a lot in various clinics. I have to unfortunately say my infectious disease colleagues get peppered with this a little bit more than others. So sorry for them. But with the closure of a lot of our mental health clinics and our community support services due to state budget cutbacks, you're going to see higher acuity patients coming to their primary care doctors for lack of somewhere else to go. And I cannot think of anything that is going to ruin the primary practitioner's day than someone coming in and saying that, all right? But what I want you to do is try to get a little bit more comfortable with it, and I'm going to use an analogy for you. Suicidal ideation is the chest pain of psychiatry, all right? If someone from the ED, now hear me out. If someone from the ED calls you and they say, oh, this patient has chest pain and it's substernal and yada, 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 you go, okay, this could be a myocardial infarction, but it could also be GERD, okay? It could also be an esophageal spasm. It could also be anxiety. Not all chest pain needs to go to the cath lab. Not all suicidal ideation is the same. Okay, you have suicidal ideation with a plan to cut their throats. You have excited utterances. You have passive suicidal ideation. You have manipulation. It is 20 degrees outside. I have no home. I am suicidal because there is heat in the psych unit. All right, there's all grades of suicidal ideation. So what you have to do is partial it out because you can't read their minds. But you can judge suicidal ideation just like you judge chest pain by risk. All right? Is it current or not? All right? Are they having these thoughts right now? Or when did they last have them? And this came up a lot in the cardiology service because they had a program at one time that they would screen people on admission if they've ever had suicidal thoughts. And this guy would come in with chest pain and he said, yeah, I did have thoughts life wasn't worth living 6 years ago. Psych consult. And there's absolutely nothing wrong with the guy other than the fact that he needed a cath. Okay? So 6 years ago is relevant, but it does not necessarily matter to the issues at hand, which is whether or not you need to hospitalize them. Active versus passive. What do I mean by that? Active suicidal ideation is I have a plan to go run out in the street and I'm going to wait for the first truck that comes by to hit me. Okay? They are taking an action to end their life. Passive suicidal ideation, which you have heard a lot. Oh, dear Lord, if this doesn't get better, I just hope you'll take me. All right? That is waiting for something to happen. And there are plenty of people who see you every day, because I see them over in Psych Clinic, who get up every morning hoping that a lightning bolt is going to strike them and take them from this world. Okay? But they're not going to do anything to make that happen. All right? Passive statements are not active. If they're not going to have a definitive thing that they're going to do to themselves, that is not active suicidal ideation. So passive suicidal ideation I kind of call ischemia. Active is ST elevation. Okay? Just to kind of keep this clarified, think in medical terms. If you have active suicidal ideation, you need to assess further plans and intent. What are they going to do? Okay? And that's how you really decide whether or not they need to be hospitalized. Suicidal ideation with a plan and intent needs to go somewhere. Now that can become problematic, especially if they don't want to go. But what I usually recommend is you have to hospitalize them. And if need be, you have to involuntarily commit them. Okay? Because a lot of times they're not going to go. The other extremely important point, and I still see it in progress notes, contracts for safety are both clinically and medico-legally useless. Do not tell anyone, do you promise me that you're not going to hurt yourself? They're going to go, sure. And then they're going to go home and hurt themselves. That is a medical malpractice lawyer's dream, is for you to let a suicidal patient go home on a contract for safety. Never, ever, ever do it, ever. Okay. Risk factors, noteworthy in two groups. Older people and younger people. Older people are a bit more reconciled to the prospect of death, especially elderly white males. They are far and away the highest group to do this and be successful at it. And young people age 15 to 24 because of impulsivity. So you have two spikes in your age group as far as a risk is concerned. All right? Single people or folks who live alone are way more likely than married people who live with someone. Males greater than females. Caucasians greater than American Indians, greater than Asians, greater than African Americans. Okay? Christians are way less likely to do it than atheists. Okay? Religious preference is protective. Okay? Even having pets is protective. I have a borderline right now who would kill herself if not for her cats. It is the only thing that is keeping her alive. And when those two cats die, she is going to jump right into the grave with them. No doubt in my mind. But those two cats are keeping her alive, so I'm going to take what I can get. Okay? Psychiatric stability, okay, and past suicide attempts. We do what we have done. So if they've tried to hurt themselves 4 times, you need to really be careful, because eventually they're going to get it right. Okay? Family history of suicide, a history of substance abuse. 50% of completed suicides had a substance on board, and it is usually alcohol. All right? Any other history of impulsivity, availability of social support. High-functioning people, even if they're suicidal, I will let them go home, providing that their husband or their wife or their grandmother or whoever is reasonable, can monitor them, understands the situation, and can contact the ED if something, or EMS if something happens. You don't necessarily have to admit every single acutely suicidal patient, but you need to document that that social support is reasonable and sound. Okay? Access to means to harm themselves. A very jarring study came out not too long ago that showed 40% of parents who had suicidal children, if they had guns in the home, psychiatrists told them, remove the guns from the home. At 30 days, still had not removed the guns from the home with a suicidal teenager. Okay? Not a good idea. Okay? Remove the access to means, okay? And then what's happening right now? And always worry about the word hopelessness. When you hear a patient say hopeless, that should make sphincters inside you tighten. It is not a good sign to hear that word in a suicidal patient. Okay? So this is how psych clarifies it. You have low risk, intermediate risk, and acute high risk. And based on what you're doing, you add up their risk factors versus their protective factors. And if the protective factors are far outweighing the risk, then in all likelihood, they're going to be okay. All right? If they've had no suicide attempts, if they've only had one psychiatric hospitalization 8 years ago, they're married, they've got kids, they've got pets, they're Catholic, likely they're not going to do this. Can you say that with all certainty? No, you can't. But if you take the time to document a suicide risk assessment and they hurt themselves, it's not going to come back on you. Okay? Psych does it all the time. And the reason for that is you can't read anybody's mind. So all you can do is manage their risk. If the risk factors outweigh the protective factors, then you call psych and you get them admitted and let us deal with it. I say this because if you have psychiatry, naturally you're going to call them. But a lot of you residents and medical students may go to an area where you have no psychiatry, okay? Like Lenore County, for example. And you're going to be on your own. So you need to be able to document this and think through it appropriately. Okay? So how well does this work in primary care? Okay? Similar outcomes in primary care versus psychiatric settings. So when managed aggressively, the internist does it as well as the psychiatrist. These are for quiz, quick inventory depressive symptoms, Hamilton D depression, and the quiz SR. They're about the same. Okay, now this does not take into account major depression with psychosis. It does not take into account 17 drug failures. This is average depression across scores that's not too complicated. The internist does just fine. Okay, so what else did the STAR-D and MDC studies demonstrate? The STAR-D is the sequenced trials for alternative regimens for treatment of depression, and this is the measurement-based care study. These are the two big trials where all this that I've talked about have come from. Okay, providing an adequate trial is key. Maximal but tolerable doses for at least 6 to 8 weeks before you give up on the drug. Okay. Psychotherapy is also reasonable. Psychotherapy has no side effects. You just have to pick the proper patient, okay? If they're capable of communicating, they're capable of insight, and they're willing to go, they're reasonable for therapy, okay? And what I tell people is, especially for mild depression, you will probably get just as good a response as with a drug. So just like you need to pick 4 drugs and learn them, you need to learn one therapist in your area that is credentialed. And you can go to a website. It is www.lcswcredentialing.org, and you can look them up, put in your town, and a name will pop up. Learn that person's name, refer to that person. That is your therapist, okay? If you're fortunate enough to have one in your clinic, which we would hope is the future, refer to that person. But just learn a therapist. It will serve you well in the future. Okay. Does collaborative care, especially co-management of depression, improve comorbid medical illnesses? Probably nowhere has this been demonstrated as well as with diabetes, and Wayne Cottrell at the University of Washington is the pioneer for this. And what he did was he randomized people with diabetes compared to controls to an intervention group that had a therapist in-house that managed the depression. Okay. And what he found at 8 to 9 months was that the A1Cs went down, the LDLs went down, their systolic blood pressures went down, right along with their depression. Integration of care and co-management of care is our future. Now, I can easily see at some point 10 years from now, at the rate we're going, we're all going to be in the same kind of house like Physicians East, and you're going to be able to walk right down the hall and speak to your psychiatrist because you've got a patient that's freaking you out in the room. That is our future, and it's honestly a preferred future. Okay? All right. What if your initial attempt does not produce remission? Now, this gets into the idea of augmentation. Let's say you got them on Paxil 60 and you can't push it anymore, and they've gotten better, but they're not over the hump. Because, again, you're shooting for remission, not response. You can add Wellbutrin to that, or you can add mirtazapine. They mix just fine. There is not absolutely a single problem with adding either one of those drugs to an SSRI because they don't target the same things. So you're not going to have additive side effects. They mix quite nicely, and you'll get synergistic effects, okay? I add this if they're lumps in the bed. They can't get out of bed. They've got no energy. I'll go with Wellbutrin. If they're not eating and they're not sleeping, I'll add mirtazapine. So I let their symptoms guide my choice. Should you use Abilify? I would say no, and here's why. Okay, it did get FDA approval in 2007 for augmentation. Next time you hear that commercial, listen to it carefully, because what the commercial will say is, have you tried Abilify for your depression? Not have you tried Abilify as an augmentation agent for your baseline antidepressant. That is not how they pitch it. And that is why you'll have your patients coming in the clinic going, can I have this drug for my depression? Because that commercial looked really nice. Okay? 2 controlled trials, about 350 per trial. They did not use a screening instrument. They did not use a validated tool in either study. They used before and after surveys. Hardly validated science. Okay? Also, there was a lot of controversy because some of the data that might have pointed away from Abilify was not included in what was sent to the FDA. Now, they deny that completely, but multiple people have come out to speak to that. So I don't know that all the data was reviewed by the FDA when it got approval. That said, it does have an advantageous metabolic profile, and I will use it if they've got major depression with psychotic features. Again, that's not something you're going to be dealing with. How much does Abilify cost per month? $800. Okay, so with that questionable data and what I've shown you from 9 head-to-head trials with 16,000 patients, where is your cost effectiveness in using this versus Zoloft for $3.50? Okay, so keep that in mind when patients ask you about Abilify. Okay, with appropriate care, the response is positive. If you follow this through with sequential visits, you've got nearly a 70% response rate. Okay. So finally, some prescription tips. They're all likely to be effective, selection based primarily on a benefit or avoid particular side effects. Okay? With coexisting anxiety, start the dose a little bit lower and titrate it up high. For anxiety, you're going to need a higher dose of anything compared to depression. Anxiety is much tougher to treat than depression, and that's an entirely separate talk. The first 4 to 6 weeks is when they're at greatest risk to stop, so keep them going. Even if you have to have the nurse call them, in 2 to 3 weeks, are you still taking it? Yeah, good. I'll see you in 3 more weeks. partial but less than complete response, you can add one. Remeron, mirtazapine, or Wellbutrin are reasonable options. After 2 failures, call psych. They're probably refractory. Okay? The PHQ-9 is easy, effective, and quick. So learn it and use it every time. Okay? Ensure a maximum but tolerable dose for at least 8 weeks before you decide that it has failed. And shoot for remission, not response. Okay? Switch or augment is reasonable, okay? The likelihood of remission substantially decreases, and some will require more complicated regimens. I have patients on 3 antidepressants at one time, and they're still depressed. And so then I'm taking them for ECT. Questions? Stop right on time. Sir?
Anything coming down the pipeline in terms of faster onset of that depression?
Nope. Sorry, I wish I had a better answer. We're not going to know how to design those drugs until we know why the current ones take 4 weeks to respond. Because again, the pharmacological effect, you bump serotonin in that presynaptic cleft a half hour after you take the drug. There's no answer or even idea as to why it takes so long. Until we have that answer, we won't have one. So what I tell people is, you got to wait. I'm sorry. Dr. Cook.
We use a lot of these $3.50 or $4 drugs. But how much is Remeron and how much is...
You can, and I'm going to go with Brody pricing because again, Brody is our pharmacy and we should use it. $20 for Remeron, and you can usually get Wellbutrin for about $20 to $30. Okay. I mean, it's very nice for the antidepressants as opposed to the antipsychotics. The antipsychotics are mind-numbingly expensive. Abilify is a typical price for one of the second-generation antipsychotics. But the antidepressants are cheap, and they all work. There was another. Dr. Cook.
We use a lot of Cymbalta for diabetic neuropathy. You didn't mention it in terms of how efficacious it is for depression compared to the SSRIs.
Pretty equal, especially if they've got a chronic pain benefit. It's probably a bit more efficacious because you're knocking out the pain, which is feeding the depression, just like you're doing with the depression. I left out Cymbalta for space and time restrictions, but it is as good as any of the other ones, and I use it a lot. Other questions?
Dr. Lang, sometimes you see patients who say they come to their spouses and the spouses say that, hey, you have those symptoms, but patients are actually in denial.
Of course.
They have those symptoms. So how do you manage that?
You believe the spouse. And here's why. Depressed patients are the last people to see their response. And it's just a cognitive dissonance relative to the disease. So I prefer to have the spouse or someone who is reliable come with them because they'll come back for their follow-up and the patient will go, this stuff is useless. I need you to switch into something else. But then the husband turns around and goes, no, she's up. She's not snapping at me. She's smiling. She's paying attention to the television. We need to keep on this. The spouse sees it first, and the spouse is more accurate. Believe the spouse. Yes, sir.
The response was
Can you speak up just a little?
The response would get the response in 8 weeks as a remission?
Well, you should get a response, okay? They should feel a little bit better. And then what you're trying to gauge from a repeat PHQ-9 is how much better are they? And then you decide based on how much their response is, how much higher you need to bump the dose.
But when do we expect the remission? Like, do we have a time?
It's, well, somewhere between 8 and 16 weeks. Some people will respond faster than others, and some people are very slow. But after your first dose titration, if that drug is really right for them, that second time around, you should see that PHQ-9 coming close to 5.
And then for how long should we keep them on?
6, if they're doing great, let's say you got them back to remission, 6 more months.
6 months.
How does your approach change for geriatric patients? Do you have specific SSRIs you'd like to use or different?
It depends. If they're really apathetic or amotivated, I will usually go with a stimulating antidepressant. So I might try low-dose Wellbutrin or low-dose Zoloft. Because again, in the elderly, you have to start lower and go slower because their likelihood of polypharmacy and their response is going to be more acute. So whatever dose I would pick for a normal adult, I cut it in half, and that's my elderly dose.
Is support system that would assist them in the suicidal ideation patients in the hospital before we go ahead and call psych?
Right now, there's a lot of debate on the current suicide screening tools, so I don't have one that I can formally recommend. So what I tell people is take a little bit of extra time in your documentation and go, protective risk factors are blah, 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 blah. At-risk factors are blah, blah, and blah. And because these outweigh each other, I think their risk is low. That's what Psych does. If you read their note, because I know most of the time you skip the bottom to see the recommendations, but if you look at the body of the note, that's what Psych is doing. They are listing positives versus negatives, and then they make a decision. Sir?
Do you withdraw medication for patients with suicidal attempts?
No. Managing suicide is a very tricky phenomenon. Let's say that they have had a suicide attempt, okay? That does not necessarily mean that the antidepressant failed, because there's lots of things that go into suicide other than the drug. You would not necessarily take someone off aspirin just because they had a TIA. So what I do is I look at what risk factors led to the suicide attempt, and then I pick my antidepressant carefully, because I may switch them if they're on something that has a high likelihood of fatality, like a tricyclic. You know, I may take them from Elavil to Prozac, because Prozac is safe for an overdose if they've demonstrated to me a potential to overdose. So I may adjust the antidepressant based on their behavior.
I meant to say, if there is a history of suicidal attempt,
they're better. Well, that's a patient-to-patient type of a decision. I don't think that there is a hard and fast rule. I will generally err on the side of caution and leave them on the antidepressant based on their number of suicide attempts. If they've had 4 or 5 in the past, I don't want to risk them getting depressed again. So that usually pushes me toward the side of long-term treatment. So the short answer is no. I would probably keep them on an antidepressant. Yes?
Suppose the patient is not able to tolerate the medication and you want to switch to another one. You don't want them to get, because the onset of the action will be out 4 to 6 weeks later.
Yeah.
What is the ideal way to switch somebody from one antidepressant?
Okay. Well, it depends on how high you got the dose when you decide to switch. As a general rule, it is always better to taper than it is to commingle. What I will generally try to do, and again, I'm a little bit more comfortable with these drugs than most, is I will taper them down. Let's say they're on Prozac 60. I will cut it by 20 milligrams every 2 weeks, just to give it a chance for the half-life to work through. And then when they're on 10 to 20 of Prozac, I may start something else, because the Prozac's on its way out as the new drug is going in, just to shorten the amount of time that they've got to be on the new drug. This assumed that things worked well. This can stretch out a whole lot longer, to allude to an earlier question, if the first drug fails. You're looking at another 12 weeks. So again, this is a game of patience. This is a long haul when you're managing depression.
Mike,
So,
a question. Great job as usual.
thank you.
And we'll take the questions down front, and thank you very much.
That was awesome.
Well, thank you.
That was great.
Appreciate it.
Great presentation, Mike. It was amazing.
Well,
Very
thank you.
helpful for your patients.
Thank you.